retrograde intrarenal surgery is a very powerful tool, and people have described using this to treat all kinds of stones, even staghorn stones. But I think you have to take it on a case-by-case basis. I think at some point, one has to realize that you've reached the limit of RIRS, and perhaps you need to switch to Plan B. Okay, so this is an interesting case. It was actually referred from a colleague. This patient had a very peculiar condition where he had a hypercoagulable state, and because of that, my colleague decided to try and treat him with what he called the retrograde intrarenal surgery, which is known to have less risk of bleeding. Unfortunately, in attempting to remove the stones, he attempted it 3 times, in fact. And what happened was the fragments moved from the kidney into the ureter and got stuck. And he managed to place a stent there, and when I saw the patient, the stent couldn't be removed either. And x-rays basically showed quite a large stone burden in the right kidney. And you can see this on the CT scan as well. So there's a very large pelvic stone, as well as some low pole components. And there looks to be some thickening of the urothelium around the renal pelvis, possibly related to the stones. And when I saw the case, you can see clearly that the stent is in place, but now you see that a large part of the stone has migrated, stone fragments have migrated down the proximal ureter, creating an appearance of steinstrasse. And there are still some components in the low pole as well. So when we attempted to remove the stent could not be removed, and it was also difficult to access the proximal ureter through the retrograde route because there was a lot of edema at that point. So this is the CT scan. You can see that the stent is basically surrounded by the stone fragments. So we have a situation where the kidney was being drained by the stent, but the stent couldn't be removed, and we couldn't reach the stones in the proximal ureter from below. Basically, we only had one option left, and that was to go by the antegrade approach. So you can see the patient is in a prone position. We can see the stent clearly and the steinstrasse and the residual fragments in the low pole. So since we are not able to opacify the kidney with contrast, we had to use an ultrasound-guided puncture. And we initially attempted an upper pole puncture to try and give us the best approach to the ureter, but that failed because of some technical issues, and the 12th rib was in the way. So we were fortunate to get through a posterior mid-pole calyx. You can see the contrast filling up the calyces. And what happened was then we used a zip wire, the 0.018 zip wire, a very thin and slippery wire, but that managed to reach down into the ureter, and then we subsequently exchanged it for a larger wire. So now we had access, and we had a wire down the ureter, and we were able to remove the stent quite easily, actually, by pulling it through the nephrostomy. And then we basically cleared the stones down the ureter using a combination of rigid nephroscopy, and then eventually we used a 16 French cystoscope, which enabled us to reach all the way down to the mid-ureter. We cleared all the stones and cleared the passage all the way down to the distal ureter. And then we exchanged it for a stent, and this was removed in about 1 to 2 weeks. You can see on the plain X-rays, I think we managed to get him fairly stone-free, but more importantly, there's excretion of the contrast down the ureter, and in the micturition phase, you can see that the contrast is drained completely into the bladder. So we think that we've managed to clear the stones, but at the back of our minds is the risk of developing a ureteric stricture because of all the surgery he's had. So he'll probably need to have a follow-up contrast study in about 3 months' time, just to make sure that there isn't a stricture. But otherwise, last I saw him, he was well, and he's back on his anticoagulation. I think RIRS is a great tool, but it has its limits, and I think one has to know when maybe there's a need to switch to something else. Sometimes you can actually treat ureteric stones through PCNL, and I think it's a very reasonable option because it's much more efficient. And I think in the past people were afraid of complications from doing PCNL, but nowadays with miniaturized instruments, the tract size is quite small, so the morbidity is much less. So for proximal ureteric stones, I think in certain cases, PCNL is actually possibly a better option.